to Pediheart, Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I'm also the Chief of Pediatric Cardiology. Thank you very much for joining me for this 307th episode of the podcast. I hope all enjoyed last week's episode on the concept of the left ventricle in patients with Ebstein's anomaly. We spoke with Advanced Imaging Fellow Aditi Gupta of the University of Pittsburgh, and for those of you interested in cardiac MRI as well as the LV in the setting of Ebstein's anomaly, I'd certainly recommend you take a listen to last week's episode 306. As I say most weeks, if you'd like to get in touch with me, it's easy to remember my email. It's pediheart@gmail.com. This week we move on to the world of cardiovascular transplantation. The title of the work is Impact of Prolonged Ischemic Time on Pediatric Heart Transplantation Outcomes, Improved Outcomes in the Most Recent Era. The first author of this work is Scott Auerbach, and the senior author Jean Balweg, and the authors come to us representing the Pediatric Heart Transplant Society. The first author, Dr. Auerbach, works at the University of Colorado. When we're done reviewing the paper, Dr. Auerbach has kindly agreed to speak with us about it. Therefore, let's move straight on to this article, and then a conversation about ischemic times and outcomes in pediatric heart transplantation. This week's work is basically intended to assess the impact of ischemic time on outcomes of pediatric heart transplantation. And why might this matter? Well, ultimately, transplant specialists need to make critical decisions regarding donors for their patients. And one of the most important factors, traditionally, in their decision-making is distance of the donor to the potential recipient. Given older literature suggesting that longer ischemic times can be associated with worse outcomes for a transplant patient in general, transplant cardiologists have a difficult time in weighing the idea of taking a heart from a distance with an associated longer ischemic time, with the risks of not taking a heart and incurring the morbidity or even mortality associated with waiting for that perfect donor. The authors suggest that avoidance of a long ischemic time donor may result in mortality while waiting for a closer donor, and point to prior literature demonstrating that the risk for death on the transplant wait list was 1.5 times more likely for patients whose transplant programs passed on a donor, meaning that if one could prove that longer ischemic time was not associated with as bad outcomes as has been considered in the past, there may be a substantial impact on overall outcomes of patients needing heart transplantation by demonstrating the feasibility of donors who have a longer ischemic time. With this as a background, the authors explain that a clearer understanding of the impact of ischemic time on graft outcomes is therefore quite important to help optimize donor acceptance decisions. And so, to quote the authors, the purpose of this analysis was to compare graft outcomes based on donor ischemic time while controlling for other known risk factors for graft loss. It was our hypothesis that the effect of ischemic time on graft loss has decreased compared to earlier eras, and that recipient risk factors are most impactful on graft outcomes. The authors explain that this is a Pediatric Heart Transplant Society study, or PHTS, including data on patients younger than 18 at the time of listing for heart transplantation, and we've reviewed this database in multiple prior episodes of Pediheart, and there are now over 60 participating centers throughout the world, and the authors review how there are even centers in Canada, Australia, Brazil, and the UK in this database. In all, there were 6,765 patients in the database, and the authors stratified by diagnosis and era, with the eras being 1993 to 2004, 2005 to 2009, and then 2010 to 2019. Median follow-up was 4 years, but analysis was truncated at 3 years for assessment of longer-term associations between ischemic times and different outcomes. Prolonged ischemic time in this work was defined as being longer than 6 hours. For this work, severe graft failure was defined as death, retransplantation, or need for mechanical circulatory support in the first 7 days post-transplant. Multiple descriptive statistical methods were used in comparing differences between patient characteristics and ischemic time, and the authors performed a multivariable analysis for graft loss and severe graft failure, using hazard and logistic regression modeling, respectively. The statistical methodology is quite robust and is quite interesting, and I would encourage those interested to read the paper, especially page 1144, and the link to the paper is in the show notes. And on to the results. Of the 6,765 patients in this database study, 48% had a primary diagnosis of cardiomyopathy, with 48.8% having a diagnosis of congenital heart disease and 3.2% something other, such as myocarditis, a cardiac tumor, or for patients in which it was not specified. So again, a roughly 50-50 split between cardiomyopathy and congenital heart disease. The overall ischemic time in the entire group was 3.6 hours. In this work, the congenital heart disease patients were younger, more likely to have a longer ischemic time of greater than or equal to 4.5 hours, and the congenital heart disease patients were not surprisingly more likely to have an ischemic time greater than or equal to 6 hours. 5.9% of the group had such long time, versus cardiomyopathy patients, in which it was only 2.4% having such a long ischemic time. Congenital heart disease patients were also more likely to require either ECMO or mechanical ventilation at the time of transplant, but much less likely to be on a VAD at transplant. They were also more likely to be HLA sensitized. And so the most important question, what was the impact of ischemic time on outcomes? Well, ischemic time was associated with early graft loss with a hazard ratio of 1.012, but this was not true in the most recent era of 2010 to 2019. Ischemic time was also associated with severe graft failure, with an odds ratio of 1.016. It's important to note that though there was statistically significantly worsened outcomes with longer ischemic time in regards to graft failure and graft loss in the first two eras, the impact of diagnosis, specifically congenital heart disease, was much greater, with a hazard ratio of 3.06 versus those with cardiomyopathy. ECMO at transplant was near to a hazard ratio of 4. In other words, ischemic time was important, but there were other far more important factors influencing outcomes in this complex patient group. To summarize this, the authors state, and I quote, "Characteristics associated with late graft loss, listed in descending order of hazard risk, included diagnosis of congenital heart disease, black race, ventricular assist device at transplant, and U.S. governmental insurance. A prolonged ischemic time was not associated with graft loss in the constant later phase." The authors have a nice Kaplan-Meier survival estimate for graft loss curve for the entire cohort across eras, showing that the change from the early phase to constant occurred at about 6 months out from transplant. It's important to mention that having a transplant in the current era was independently associated with a lower risk of graft loss, both early and late, with respective hazard ratios of 0.5 in the early phase and 0.56 in the later so-called constant phase. And again, in the most recent era, longer ischemic time was not an independent risk factor for graft loss, although it was for severe graft failure. In regards to severe graft failure, 5.2% of patients in the most recent era developed this outcome, and among these 191 patients in that group, 10% died and 72% needed ECMO, with 2 patients needing ventricular assist devices and 2 needing retransplantation. The authors conclude their results section by explaining that longer ischemia time was associated with more infections and more rejection on univariate analysis. In their discussion, the authors state, and I quote, "This analysis found that while ischemia time was an independent risk factor for graft loss, the effect size was small relative to other factors, such as congenital heart disease, ECMO, and others. Most importantly, survival after transplant with an ischemia time of greater than or equal to 4.5 hours has improved over time. Most of the impact of ischemia time of graft loss was due to transplants occurring prior to 2010. When graft loss was analyzed in different eras, we found a higher incidence of graft loss in the first 2 eras. Multivariable modeling showed the most recent era to be protective when compared to the other 2 eras. Additionally, multivariable hazard modeling of only patients transplanted in the most recent era did not find ischemia time to be an independent risk factor for graft loss. However, in the most recent era, we did find an association between ischemia time and severe graft failure, suggesting that some of the improved graft survival may be related to better postoperative management of severe graft failure rather than decreased incidence of severe graft failure. The percentage of patients in our analysis with this problem, 4.2%, was similar to recent analysis of primary graft dysfunction in the Organ Procurement and Transplant Network database, suggesting that our definition of severe graft failure was a reasonable surrogate for primary graft dysfunction. The authors comment on how ischemia time did not seem to affect outcomes in the cardiomyopathy patients up to 6 hours, but ischemia times greater than or equal to 6 hours were an independent risk factor for graft loss in this cardiomyopathy patient group. They mention how most of these long ischemia time cardiomyopathy patients and deaths were in the earlier eras and occurred early on after transplantation. They wonder if the longer than 6-hour ischemia times doing worse may reflect how well those less than 6 hours did, rather than bad outcomes for those who had very long ischemia times. And they mention how encouraging it is that survival and outcomes have improved with time for cardiomyopathy patients who have ischemia times that exceed 6 hours, despite the additional risk with this length of time. They re-emphasize how having congenital heart disease was a definite, important risk factor for graft loss, but how in that patient group, ischemia time was not an independent risk factor for graft loss on multivariable hazard modeling. They explain that the longer ischemia times seen in congenital heart disease patients are likely due to higher complexity of these transplants with the greater need for complex reconstructions, and how in this patient group, recipient factors like the presence of congenital heart disease, for example, were far more important risk factors than ischemia time. To quote the authors, these findings support the idea that improvements in patient selection, organ preservation, surgical techniques, and/or postoperative management in the most recent era may be responsible for the overall improvements in outcomes in patients with congenital heart disease with longer ischemia times. The authors re-emphasize how in the recent era, infant transplantation less than 1 year of age is associated with markedly improved outcomes in comparison to prior eras. They mention how having a VAD in this multivariable analysis was associated with a higher risk for graft loss, but how this differs from prior large-scale works, and they wonder if a more granular evaluation of the data might explain this disparity. In regards to limitations, the authors comment on the retrospective nature of this work and how this type of analysis can only point to associations rather than causes. They mention how panel-reactive antibodies, or PRAs, were reported differently in the different eras, making this important risk factor harder to compare between eras. They speak of how only 3% of the entire group had an ischemia time greater than or equal to 6 hours, limiting the information we can glean from that smaller subset of this cohort. The authors also point to the fact that the database has only the total ischemia time and not the warm versus cold ischemic time, and that these times may offer insights into these outcomes. They mention how severe graft failure was only reliably captured in the dataset in the recent era, making these sorts of analyses regarding this particular outcome more challenging, particularly in comparing eras. And so they conclude, longer ischemia time was a risk factor for graft loss when viewed across all eras of pediatric heart transplantation. In the current era, ischemia time was not an independent risk factor for graft loss, but it was a risk factor for severe graft failure. While the risk of graft loss with ischemia time out to 6 hours and possibly beyond did not independently confer an increased risk of graft loss in the most recent era, there was still risk of severe graft failure. Based on this analysis, with good donor heart function and current methods of myocardial protection, donor heart ischemia time out to 6 hours should be considered safe. However, the ischemia time should be considered in the context of other recipient characteristics, such as pre-transplant ECMO and congenital heart disease, when preparing for postoperative care and risk stratifying for severe graft failure. Well, this is quite interesting and encouraging. How nice to see that longer ischemic times, at least till 6 hours, are not at the present time associated with graft loss, though graft failure is still a concern. That said, the authors rightly point out the myriad other risks that are far more significant. To some degree, I think this is an important report because it may suggest to our transplantation cardiologists and surgeons that we don't need to use ischemia time to be as much of a hard stop when considering acceptance of a heart. I'd like to know what Dr. Auerbach considers to be the reasons that in today's world we can accept a heart more safely with a longer than usual ischemia time, and also what role the so-called heart-in-a-box perfusion systems that presently exist may play in these improved outcomes, and if he thinks that perhaps the use of this type of technology may even further lengthen allowable ischemia times. In the interest of time, therefore, I think we should move on to our conversation with the work's first author, Dr. Scott Auerbach. Joining us now to discuss this week's work is Dr. Scott Auerbach. Dr. Auerbach is a graduate of the University of California in San Diego for medical school, followed by residency in pediatrics at Stanford University. Following this, he completed general cardiology fellowship at New York Presbyterian Columbia University, and then went back to Stanford for advanced heart failure and transplantation training. Today he is Professor of Pediatrics at the University of Colorado, and he is also the medical director of the Ventricular Assist Device Program at Children's Hospital of Colorado in Aurora, Colorado. It is a delight to have my friend Scott back on the podcast to discuss this important work. Welcome, Scott, to Pediheart. I'm here now with Dr. Scott Auerbach, the University of Colorado. Scott, thank you very much for joining us this week on the podcast.
Oh, it's my pleasure. Thanks for the invitation.
Thanks a lot, Scott. Really appreciate it. I very much enjoyed this work. Congratulations to you and all the PHTS members who worked on this with you. You know, obviously your work shows that although ischemic time is an important factor still for graft failure after transplant in the present era, graft loss did not seem to be affected by ischemic time at least up to 6 hours. I'm wondering how, as a transplant cardiologist, you think that other transplant cardiologists could use these data to inform decisions when they're on donor call, making important decisions regarding acceptance of an organ.
Great question. I think the cardiologists and surgeons reviewing a donor offer will still look at the overall ischemic time and factor it in as one of the variables in the decision-making process. I think we still need to keep in mind that a longer ischemic time will still potentially have negative effects on graft function and is a risk factor for primary graft dysfunction, which is when there's ventricular dysfunction immediately post-transplant that requires high doses of inotropes or mechanical circulatory support. Recipient factors have been shown to be more important with respect to survival and graft function than ischemic time, not only in this study, but in multiple other studies as well. But as a field, I think we've been doing a better job of keeping people with primary graft dysfunction alive post-transplants, despite the rates of primary graft dysfunction being around 4 to 5%.
I see. You know, Scott, in the discussion of your work, you discuss cold versus warm ischemia and how these different types of ischemic times could have an impact on outcomes. I'll be honest in telling you I don't really know what that means, and I'm wondering if you could explain what each of these types of ischemic times are and why they're used and what impact one versus the other might have on outcomes.
Yeah, so the warm ischemic time is typically defined as removal of an organ from the cold storage to completion of reperfusion of warm blood following anastomosis. And cold ischemia time is the duration of time an organ spends in the cold storage prior to transplantation. There are some data in adults that the warm ischemic time may be, a longer warm ischemic time can have a more negative impact than the cold. It's not really clear in pediatrics if that's really true or not. And we haven't really consistently kept warm ischemic time in our registries, so it's tough to know how much of an impact it has relative to the cold ischemic time. I think in general, we think that the longer the warm ischemic time, the more likely the cellular function of the myocytes is going to break down.
And so the total ischemic time, like when they say the ischemic, like you're in rounds in the ICU and they say the ischemic time was blank, that is both cold and warm together, or is that just reflecting cold ischemia?
It is typically, the entire ischemic time, including both the combination of warm and cold, usually. Unless somebody specifies one or the other, we're usually talking about the entire time.
I see. Scott, I was wondering what you believe are the major factors that would, in the present era, explain why, in your study, the longer ischemia times were not having as much of an effect on graft loss as they did in the earlier eras. Was this just a reflection of better post-operative practices, better anti-rejection therapies? I wondered why you thought they seemed to be doing better with patients who had a longer ischemia time.
Yeah, good question. I don't think the rates of primary graft failure have been changing much. Dr. Elizabeth Perfute, who's now at Stanford, who published a paper when she was in Boston, found that over time, the incidence of severe primary graft dysfunction ranged from about 4 to 5%, regardless of the era. In our study, we found severe graft dysfunction occurred in about 4%, so we felt pretty good about creating a surrogate definition of primary graft dysfunction. We don't keep that as a standard field in PHTS. So I think a combination of preoperative and postoperative care has led to the improvement in overall survival. Prior to transplant, I think we're doing a better job of understanding risk factors for poor outcomes and getting patients to a point where we're intervening on modifiable risk factors better than we have in the past. I also think we're continuing to see improvements in postoperative care. We're recognizing primary graft dysfunction earlier and providing mechanical support earlier in the course to avoid things that exacerbate primary graft dysfunction, like hypercalcemia or high doses of inotropes.
I see. Well, for those in the audience, I got Scott right in the middle of his day, just as his day is starting in Colorado, so I'm going to finish up with this last question. I was wondering, Scott, how commonly are you guys using this so-called heart-in-a-box perfusion systems that I notice are used to preserve organs after harvesting but before implantation? Are there data to support their use in kids? Are there downsides? And I'm wondering if you think this type of technology will potentially even allow for longer ischemia times.
Yeah, I think there's a lot of enthusiasm for these systems. And the use of organ procurement systems is increasing in pediatrics. The two systems that are being used are the Paragonic system for cold storage that works with any size donor and regulates temperature between about 4 to 8 Celsius to prevent tissue from freezing. This is also known as the Sherpa pack. And the other system is the Transmedic system, or the Organ Care System, OCS, in which donor organs immediately go on a pump device after surgical removal. And that machine circulates warm oxygen and nutrient-rich blood. And there is an ischemic time for that going on pump, and then from the time of removal to anastomosis. But the ischemic time seems to be consistently in the 80-minute range or so, give or take some. With respect to the Sherpa pack, most of the data are available in adults. Well, for both actually, most of the data are available in adults. With respect to the Sherpa pack, patients with ischemic times more than 4 hours had lower likelihood of needing mechanical circulatory support and severe primary graft dysfunction. There was overall improved 30-day survival. But in pediatrics, the data is just not as robust, and I think we don't have enough data yet to show an improvement, but there have been some trends towards improved survival. Dr. Jeffrey Jacobs and colleagues presented Guardian registry data, which is the Sherpa pack registry, and this showed there was a trend towards survival in pediatrics, but it did not quite reach statistical significance. There's 98% survival with the Sherpa pack versus 91% in cold storage. And there is a single center study from Stanford that also Dr. Profita again. They presented their single center experience. They found that there was really no significant difference between cold storage and the Sherpa pack. However, this was a smaller group of, I think, 20-something patients.
So, Scott, are most centers in the present era using this now, or is it still kind of 50-50, or how do places think about it? Like, what do you do in Colorado? Do you use this
I think
type of equipment?
we want to use it. We don't have it yet. It's a bit cost prohibitive, but one of the recent publications has shown that actually, if you look overall, with the reduction in mechanical circulatory support in adults, they found it cost effective to use it. We are planning to use it in Colorado. We just don't quite have it yet.
I see. And are most pediatric places doing it, or not really? I think at Sinai we're using it actually now.
It certainly is increasing. I don't have the exact numbers about how many centers are actually using it now, but I know there is a significant percentage of pediatric centers that are using it. With respect to the Transmedic system, the first one was done in the U.S. At Duke. And at the last ISHLT meeting in Prague, Dr. Emma Dury from Mayo presented a series of 3 patients. And these are all, adolescent age patients who, had either long ischemic times relative to the distance for procurement, or we're going to require complex reconstructions at the time of transplant. And they were able to show that there was a reduction in the ischemic time that would have otherwise been much more prolonged had they not used the Transmedics system. So I think that's where Transmedics is going to come into play. It's allowing perfusion of hearts while complex reconstructions are being done.
And Scott, just so I understand, when it's in that transmatic device and being perfused, you do not consider that ischemic time?
Not when it's being perfused, no.
Not when it's being perfused.
Ischemic time is only when it's going on the pump and after it comes off.
I see. Thanks. I see. Well, Scott, once again, can't thank you enough for coming on the podcast this week. I want to congratulate you, all of your co-investigators. Of course, who else but the former president of PHTS would present a paper from the PHTS? Really wonderful, advancing the field, and great pleasure to have you. Thank you.
Oh, great. The pleasure is all mine, and I appreciate you having me on the show, and I love the podcast, and I'm grateful for you putting in all the work to keep it going.
It's very kind of you. Thanks so much, Scott.
Well, not much to add to Dr. Auerbach's comments. I think we all learned a bit more about ischemic times, and I'm sure you found his comments about newer ways to preserve hearts, as well as his thoughts on why longer ischemic times seem to be associated with somewhat lower rates of graft failure than in the past, due to multiple factors, to be very interesting. I hope you enjoyed his comments as much as I did.
To conclude this 307th episode of Pediheart, Pediatric Cardiology Today, we'll once again listen to another of the beautiful Italian songs of the great song composer Paolo Tosti, when we hear the song Ideale, in which the singer sings of that one perfect or ideal love in his life, and how he longs for it, if even for a moment. Today we hear it sung by the great Modenese tenor Luciano Pavarotti in a performance from nearly 50 years ago. Thank you very much for joining me for this 307th episode, and once more, thanks to Dr. Auerbach. I hope all have a good week ahead.
Io ti seguico miride di pace lungo le vie del cielo. Io ti seguì come un'amica face nella notte del velo, e ti sentii nella luce, nell'aria, nel profumo dei fiori, e fu piena la stanza solitaria di te, dei tuoi splendori. In terra rapito al suon della tua voce, lungamente sognai, e della terra ogni affanno, ogni croce in quel giorno scordai. Torna, caro ideale, torna un istante a sorridermi ancora, e in me risplenderà nel tuo sembiante una novella aurora. Una novella aurora. ciel in quel giorno scordai. Torna, caro ideale, torna un istante a sorridermi ancora, e in me risplenderà nel tuo sembiante una novella aurora. Torna, caro ideale,